Hello and welcome to this ACR review podcast brought to you by the Lupus Forum. My name is Ed Vital. I'm at the University of Leeds in the UK and I'm the chair of the Lupus Forum. And today I'm once more joined by my colleagues and friends who were also at ACR this year. Professor Viveka Strand is an adjunct clinical professor of immunology and rheumatology at Stanford University School of Medicine, and Cindy Aronow, who's director of the Clinical Autoimmunity Center of Excellence at the Feinstein Institute for Medical Research in New York. So welcome, both of you.
Thank you. Nice to see you.
Yeah, nice to see you face to face in California and online again now. So there was lots of lupus content at this ACR, I think, and we've captured quite a bit of that. We put the top abstracts in our highlights brochure and in our daily highlights. And in this podcast, we're going to discuss the lupus data that really stood out for us personally at the conference and the things that we think are going to be defining clinical practice in the near future or further off. So, Viveka, do you want to kick us off and start telling us what you found most interesting or most thought-provoking at the conference?
Well, I think probably everyone found that CAR T cells were the star of the conference. And it's really interesting because basically it's 15 patients across 3 indications. We have 9 lupus patients and 3 systemic sclerosis and 3 inflammatory myositis patients treated by Georg Schett's group and Erlangen. And then we have some other posters and abstracts that talked about either those same patients or a few more. It's already gotten to the point that 3 US companies are busily working on CAR Ts in lupus and lupus nephritis. Cabaletta had a poster, and so did Kyverna, and so did Novartis. And Cabaletta was actually reviewing patients that had been treated along with Schett and talking about changes in TNF and IL-6. It went down, and IL-7 and BAFF that went up. And there was a lot of discussion about, well, how far out are these patients and how long would this drug-free remission act? And basically the Erlangen group has 10 patients out to about a year and 4 out to about 2 years, they're all seemingly in complete remission, with the longest being 2.5 years of follow-up. I think Georg Schett is really modeling that something like 3 or 4 years will be about the time that they'll stay in remission. But as of right now, it's a big question. There's also a question too, such as manufacturing techniques and timing. Novartis made a point that their manufacturing was more rapid, and therefore you would see the depletion sooner, and then you would see repletion faster, and that maybe that would be different and, shall we say, more positive. Kyverna had a couple of patients that were also treated with lupus nephritis and follow up very briefly, and like the Novartis patients, seemed to be doing well. And then there was a nice demonstration of vaccination responses that were maintained in the Erlangen group of patients, which gives us some confidence that we're depleting, shall we say, the right cells and not depleting all of the memory cells and long-lived plasma cells and plasmablasts. But there's a lot of question about this. And personally, I've never remembered any excitement about something that was tried in a total of 15 patients before. And I wonder what you think, Ed.
Yeah, exactly. I was going to say, I'm pleased to hear that you're slightly cautious about the hype, because I am a bit too. And partly it's that level of evidence. You know, I remember when we first used rituximab. David Eisenberg's first paper was 2002, and he said 5 patients, B-cell depletion, 18 months remission, I've cured lupus. Like, that's 20 years ago. So, you know, yeah. I just have this slight feeling of deja vu, and it's not. But I don't mean to be too like facetious or anything. Like, I do think it'll be an advance. I think for some people this will be a lot better therapy, but I think I have a slightly sort of theoretical objection to the idea that this is the way to cure lupus, personally, actually. That, yes, it's true that the problem with rituximab is it didn't deplete B cells deep enough.
Right.
Lots of people told me that, and actually I knew because it was my thesis. But so this should deplete deeper into tissues, and we know that the repertoire reset you get after rituximab, at least in RA, isn't always complete, and this should do that a bit better. So that is quite encouraging. But I think the problem is I think this is all predicated on the idea that the reason you've got lupus is because one day a B cell had some random event that made it autoreactive under some environmental hit, I suppose, or multiple environmental hits. And then once that happened, that mistake couldn't be forgotten because of constant antigens, so they proliferate. And therefore, that if you just do a one-off depletion that's deep enough, you'll reset all of that and you'll restore tolerance, which is a bit of an incomplete, it's not crazy, but it's a bit of an incomplete theory of lupus. Because like most of the genetic susceptibility of lupus isn't in lymphocytes, it's in innate immunity, and some of it's not even in the immune system at all. It's like DNA damage, repair, and clearance and stuff like that. And so I don't know how you can possibly clear that with a one-off depletion into B cells, no matter how deep you go. It's like the lupus is in the soil. And there was that paper in Nature by Carola Vinuesa where it was a TLR7 mutation, which basically induces a load of extrafollicular B cells and gives you lupus. And that's not really kind of antigen specific, like the way that'll just recur. So there are some things, there are things I want to see really to convince me. So I suspect there's a certain type of patient where this is the right thing.
Yeah, I do think that we'll be using it in some patients.
Yeah.
Cynthia?
Yeah. So just to build on what you just said, Ed, is that so the autoimmunity goes way back in terms of the B cell lineage. And when we know in normal patients or healthy controls is that those autoimmune cells are deleted at certain checkpoints during B cell maturation, and whereas in lupus patients they are not. And what I don't understand is how what happens with those checkpoints can suddenly be abrogated. And as you said, there are environmental triggers, there are other pieces, but just getting rid of all the B cells is not going to necessarily get rid of what happens in an autoimmune individual, in a patient who has a predisposition to autoimmunity, and is not going to be depleting those B cells as they mature during their normal maturation. And I think we know that lupus is incredibly heterogeneous, and there are many roads lead to Rome. And this may be a great treatment for some, but 15 patients is still just a little bit, and we just don't know if this is going to work, how it's going to work for all. Plus, how it's going to work in other patients of different ethnicities and different ancestors.
Yeah. So we don't really know who would be the right patients for this, whether we're talking about autoimmune disease or lupus. And the other thing, though, that has come out is that these patients have tolerated this lymphodepletion and then CAR T cell administration better, by and large, than the patients who've been treated with the hematologic and oncologic cancers. There's very relatively minor CRS, cytokine release syndrome, treated, I think, with tocilizumab in about 3 or 4 of these patients. There was only 1 ICANS. So perhaps this is something that will go forward as something that we can perhaps, quote, reset to some extent the immune system, but it's obviously going to be highly individualistic. And I think choosing the right patients is going to be at least one of the biggest challenges.
Yeah.
And the other thing that we have not seen yet is the vaccination response. So, they talk about preservation of protective antibodies, and they're calling those vaccination antibodies, which I think is a little misleading. They're not.
Well, Shet did do a vaccination of a couple of patients.
There were
was
three
in his
patients.
post-op.
There were three patients. One was
Mhm.
COVID, and I forget what the other two were. But again, the numbers are truly, truly small.
That's small. You're right.
One other thing on CAR T, actually, just to say that it was a bit interesting, that was kind of a bit newer to me, was that everything we've been talking about there is CD19 CAR T, which is just trying to deplete all your B cells. But people are developing some rather more interesting ways to use CAR T technology with different targets. Some of them very interesting. So there was a Chinese, these are much earlier phased, kind of animal and in vitro and stuff, but there was a Chinese study that was combined CD19 and BCMA, which makes it hit plasma cells a bit more, which might be more effective, but might come with some safety issues, perhaps. There was one against CD40 ligand. There was an RA study that was targeting fibroblasts. And there's one that was actually last year that I remembered it, which they were actually custom designing CAR Ts to a specific autoantigen for that patient. Actually taking somebody's autoantibodies, kind of working out how to program the CAR Ts to tolerate against or to block that autoantigen, which is pretty mind-blowing technology. So I guess that's another interesting angle.
Kyverna's working on allogeneic T cells, and I think if that happens, then this idea that CAR T cell therapy, $400,000, $500,000 per patient, would plummet, because it could be done much, much more efficiently and cheaply. But again, we'll have to see.
But just using so there's more to it than just super powerful B cell depletion.
Yeah, and there's some companies that are looking to make sort of where you don't need to apheresis off the patient's T cells, and you could have an off-the-shelf CAR T product that you could just infuse into anybody, trying to eliminate that need to apheresis and to make it a lot quicker. So there's still so much that we have to learn about this, and including how well it's going to work in the entire population.
Yeah. What were your other highlights then?
So there were some other interesting things. I think we've seen a lot of plus and minus with various JAKs in lupus, but upadacitinib, they presented to phase 2 that they done with a combination of upadacitinib 30 milligrams high dose with a B cell with basically a BTK inhibitor. But then when they did the interim analysis, they found out that it was essentially the upadacitinib 30 milligram dose that was the effective dose. And they're planning to take that to phase 3. But the data look quite good in that group that got the 30 milligrams. And essentially, we saw very nice evidence of inhibition of B cell markers of activation. And perhaps then this one will be a JAK that will move forward.
And those data again looked really promising, almost too good to be true. But I think the proof will be what happens in the phase 3.
Right. Then Novartis has this ianalumab, which is an afucosylated BAFF-R monoclonal antibody. So it both kills B cells and also inhibits B cell reactivity, BAFF-R binding to the receptor. So they show very nicely the B cells are depleted, the interferon gene signature goes down, and their phase 2 data, although small, look quite good. So that will be moving on into phase 3 as well.
This is one of the ones I was going to say is one of my highlights, actually, but it's good to mention now because this is the other interesting thing I thought about the CAR T story, is that the monoclonals are getting better and better. Depleting B cells with monoclonal antibodies, ianalumab, there's also obinutuzumab, and those are getting better and better, and so therefore is the relative benefit of a cellular therapy become a bit less, because obviously monoclonals you can have as often as you want and very straightforward. Ianalumab's subcut. So, yeah.
Then there's a TLR7/8 afimetron, and that was just an early phase 1B study from BMS, but they showed very nicely in patients with CLE and SCLE, CLASI A responses. And so that will be moving forward. They also showed some nice CLASI data with deucravacitinib in those patients that had cutaneous disease. So those were pretty exciting. I think that this has been better for lupus than really any of our previous meetings in the context of therapies that are moving into later trials. Good data with obinutuzumab as well, which was from the previous phase 2.
Yeah.
Right. So maybe it's time to hear your highlights, Cindy. What were the best sessions for you?
So I think that there were so many good things that were presented. And it wasn't an abstract, but there was a widely attended session early on with overflow into 2 rooms looking at early lupus and disease-modifying anti-lupus drugs. And in the first speaker, Dave Karp, was talking about early or pre-lupus, and he asked the question, can lupus be prevented? To which he answered, well, yes and no. And he spoke about staging patients with lupus, somewhat akin to type 1 diabetes, where patients with relevant autoantibodies are labeled as stage 1. And then he suggested, stage 1 with autoantibodies to nuclear antigens, then stage 2 and 3 as they progressed to experiencing clinical symptoms, and then to actually fulfilling true classification. And saying that the advantage of staging would give patients a diagnosis, a label, which many of them want to know, as well as, if we had a new potential interventions and treatments to potentially stop the progression of patients actually developing full stage 3 lupus. The second talk in this session was given by Anka Askanase, where she discussed and defined a really important topic, such as disease-modifying drugs in lupus, and proposed and that medications be considered truly modifying if they could demonstrate efficacy at 3 different points in time. And initially during the first year, that they could control disease activity, prevent flares, allow for steroid reduction, maintain this at another point during years 2 and 5, and then show that after year 5 of treatment that they actually prevented or slowed accrual of damage. So I think the concept of disease modification is one novel, but really important. And she then made the case that hydroxychloroquine, belimumab, and anifrolumab fulfilled these criteria. And, really surprisingly, we don't have data. There's not enough published data to support labeling all of the other immunosuppressives that we use and love as disease modifying. And then briefly, the last talk by Maria Dellaur focused on renal interventions and highlighted, the holistic approach that there are both immunologic and non-immunologic pathogenic mechanisms in lupus nephritis, and how important it is to target both, and emphasize diagnosing and treating early, close monitoring. We want to reduce the occurrence of renal flare. Suggested that belimumab in the phase 2 anifrolumab data, that these may be the disease modifying in lupus nephritis. And she used the term time is kidney, which I think I'm going to adopt as I speak with patients and trainees about the absolute need to treat and maintain control of lupus kidney disease. So I go to lots of sessions, at the ACR, and I think that this was, really important and really novel, and just, one of these sessions where I'm taking things home and really thinking about it to discuss with my colleagues.
I agree. Unfortunately I couldn't go to that one, but I heard everyone talking about that session about early intervention. Actually, I've also worked a bit on preclinical lupus myself, and this concept of prevention. And the main thing I notice is just that phase of ANA positivity, from which most people stay fine, but a few people progress to lupus. It's immunologically, it's much more complex than I used to think. I used to think it's just an antibody that doesn't really do any harm. And okay, yeah, it is true that most people don't come to any harm if they're ANA positive, but their immune system is profoundly dysregulated, almost exactly the same as actually SLE in most respects. And so, yes, it's intriguing. And the other thing I wonder is whether the targets you might use for drugs, if you're going to try and prevent lupus, are different to the ones that you'd use in the established disease, actually.
Yeah. And there's an ongoing study in the United States, the SMILE study, that's looking at the potential use of hydroxychloroquine to prevent the progression of disease in incomplete lupus. So these are patients who do have more than just a positive ANA. And, so this has been an area of active research in rheumatoid arthritis. And hydroxychloroquine did not show efficacy in this STOP-RA study, but it's going to be really interesting to see what occurs in lupus, which is a different disease.
So that's exciting, because we've got two themes there that are both talking about curative therapies. One with CAR T cells, the other one with preventing the disease in the first place.
So, there was another session that I went to, which I thought was really, sort of interesting, because it's something that we don't really think about, and that was lupus in Africa. So there was 3 speakers, one from Ghana, one from Nigeria, and one from Kenya, who presented data on the prevalence and features of lupus in Africa. And I think we're going to be hearing a lot more about this in the future. But the one take-home message that I got from this session is that the lupus gradient theory, which has been dogma for years, is probably totally wrong. And that is, so lupus is more severe in patients of African ancestry with more lupus nephritis. And the thought has been that it's really rare and doesn't occur in Africa, and that it's perhaps the admixture with other races or the environmental factors that are different as patients, as Africans moved away from Africa. And what I learned is that lupus is clearly present and severe in lupus in Africa, but that it's different. It is different. And in fact, ANA positivity, which is now a requirement for the ACR-EULAR classification criteria, that in some places only 80 to 85% of lupus patients were actually positive for positive ANA. And that there are also differences in other autoantibody positivity in different areas of Africa, which also shouldn't be surprising, as genetically Africa is more diverse than any other continent on Earth. So there were differences in autoantibody positivity, differences in clinical features. So, I mean, this was truly new to me, and what I get, and unexpected, what wasn't unexpected was that, the problems that they have in terms of delays of diagnosis, access to drugs. And what I heard was that the 5-year patient survival ranged from 54 to 94%. So that lower range, and their renal survival also had, you know, a wide range with a rather low 5-year renal survival. That number was 48%. And these numbers, the lower limits, are really reminiscent of the survival of lupus patients in what I'm going to call the Western world in the 1960s. So, you know, I really give credit to these rheumatologists. They're building registries and trying to increase awareness and education. But I think that this is something that we're going to be hearing about in years to come, and that we have a lot to learn.
That is absolutely fascinating. I'm constantly thinking, I talk a lot about stratifying trials, trying to find the groups of people who are higher risk or lower risk or respond better to therapy. And actually, you always come back to the same thing, which is we don't know how to code any of this stuff, because it's really, when you get terms like Asian or Black, which are just so imprecise that no one knows whether you mean do you mean ancestry or geography? And like, you know, Africa's a big place, like you say, and Asia's a big place, and these are really, and some of these things are actually socioeconomic, and you know, so we need to sort it out, actually, don't we, to understand how demographics and diversity, because it tells us what to do. Because there are some people who are clearly underserved by the therapies we use now.
Yes.
And
we're making an effort to include the African sites in our OMRACT effort, looking at domains and eventually instruments for lupus trials. So it's going to be a lot of fun to see what we learn from that too, because it is completely, really has been very much overlooked from our perception of what we think the disease is.
Yeah,
exactly. Then I did want to highlight some abstracts, but you know, depending on time. But there was a plenary abstract on acute cardiovascular events in autoimmune rheumatic diseases. This was 0722, and this was a really fascinating study in which they highlighted the increased risk of autoimmune disease in pregnancy, and what they examined cardiovascular events occurring during pregnancy and in the 6 weeks following pregnancy in patients with autoimmune rheumatic disease, and found a really outstanding increased risk of cardiovascular events in women with autoimmune disease compared to controls. And in the patients with lupus, there was a 6-fold, an incredible number, increased risk for patients for a cardiovascular event for a lupus patient, which was even further increased if they had antiphospholipid syndrome or nephritis. And additionally, which I found really surprising, was that this increase in venous thrombotic events occurred in the postpartum period. So the risk wasn't finite after actually giving birth. And so that I think that this not only highlights the need for close monitoring during and then particularly after pregnancy, but it does bring up questions of if and how we should be thinking about intervening. So I thought that this was really eye-opening.
It's a bit like your point that you said from Maria's talk, is we think about disease activity and immunosuppression. Actually, a lot of mortality and problems in lupus are not just directly from disease activities, complications and cardiovascular risk and glucocorticoid therapy, all these other things that we have to manage well to get the good outcomes. So my highlights are going to be quite quick, because we've actually already talked about most of them in that fascinating discussion. But yeah, I picked out ianalumab. I think that looks impressive. There was an obinutuzumab abstract sort of suggesting that quite short-term depletion and then allowing B cells to repopulate was kind of okay for lupus nephritis. And then I think one other highlight for me was a session. It was actually an immunology session that was about innate immunity in the skin. which is, and again, it's an area that I've worked in a bit, that really, not all your lupus is because of your immune system attacking healthy tissues. Some of it is actually these tissues themselves playing their own role. And there are now quite a few people working on themes around that the immune mechanisms within the skin, keratinocytes making interferon kappa, as Michelle Kallenberg's group have published quite extensively, neutrophil activation from the Scavelia-Gardner group, this interesting molecule called Vista that seemed to regulate the interferon response in the skin and the kidneys. So I think this is a very interesting theme. And again, it highlights the fact that just targeting B cells and just resetting B cells it may be useful, but it's not going to be the entire story of lupus. And unfortunately, whilst that's it, we could probably talk for hours, but I think that's probably all we have time for today. So I hope you've all enjoyed this review of the lupus data from this year's ACR. Thanks very much to my co-hosts, Vibeke and Cindy, for your time and your insights. And it was great to see you both at the Congress this year. As always, I'll encourage you to head on over to the Lupus Forum now. There you can find the publication slide decks summarizing the key publications in lupus, free for you to download and use for your own teaching and journal clubs. And have a look at our podcasts. They're another free resource where you can hear some of our interesting insights about these papers. And as always, if you also want to be informed about key data and abstracts presented for other diseases, rheumatoid, psoriatic arthritis, ACL, SPA, then you could look at the Cytokine Signaling Forum, where they've just posted their own review of the conference. So all that remains for me to say is I hope you enjoyed this podcast, and best of luck in your clinical practice. Bye.
Bye.